coordinating it. And thank you, Dr. Nandakumar, for letting all of us know about the delay in the session. But Dr. Ranjini is, I just spoke to her and she's on.
Do we have to wait for more people, Nandakumar?
I think we can start now. We have a recording of the section 1. So I will share it later.
Oh, okay, Nandakumar. All right then. Whoever was able to join in short notice, thank you. I'm Ranjini. I'm a cardiologist. I did my training in KMC. Looks like everyone has turned their camera. I'll turn my camera off when I start the presentation. So my training was in KMC, just like you all. Then I got married, came to the US. I did my residency in Pittsburgh, cardiology fellowship in Seattle, University of Washington. Actually, I also did a lot of research in coronary artery disease, atherosclerosis, both basic science and clinical epidemiology. Now I'm practicing as a general cardiologist in an underserved clinic called Lahai Health because the research funding had a shift. So I'm seeing more patients now in an outpatient setting. So that's my background. And I thought of talking to you all about acute coronary syndromes. If you can introduce yourself and tell me which year you are in, I can, modify the talk in between. So since there are only 11 people, can you all introduce yourself?
We are mostly second years.
Oh, mostly second year students. Okay, anyone interested in cardiology so far? All right. Do you guys get teaching on clinical cardiovascular exam yet? Murmur, physiology? Not really. Not yet.
We do.
Okay. How about EKG? Have you guys started to read EKGs?
No.
Not yet. Okay. All right. Then there are few things that I will, try to slow down, or you guys can look at the PowerPoint slides later. Let me mute my stop my video. Okay, so the reason I thought I need to talk about acute coronary syndromes is because it's the majority of disease burden and cardiology. And when people talk about heart disease, they indirectly refer to acute coronary syndromes or heart attacks, which mainly include heart attacks and also angina, unstable angina. So in terms of my presentation, I thought I'll go over some cases, look at the pathophysiology and risk factors, which you are probably getting an overview now, how to diagnose, complications, and management. I'm going to spend a lot of the talk in pathophysiology and diagnosis and cover a little bit of management, which I think is appropriate for you all. So to give you the clinical context, I have 3 cases here. First patient, 83-year-old male with hypertension, diabetes, history of chronic tobacco abuse. He has chest pain with right arm weakness. It started a week before. And on exam, he has signs of congestive heart failure. ECG shows ST depression in V1, V3, and troponin is elevated. So in terms of thinking about differential, stable angina, acute pneumonia, acute non-ST elevation MI, pericarditis, and unstable angina. So I was assuming there'll be some clinical students joining as well. So I thought I would quiz you guys, but if anyone has any thoughts to the diagnosis, you can just unmute and tell me. Few seconds, I'll give you a few seconds. No? Okay, I'll move on to another case. I'll go over the cases once I present my slides. This is another patient, 70-year-old male with chest pain on exertion. He has a positive stress test and his ECG is normal. Troponin is negative. What is the diagnosis? Again, various cardiovascular diagnosis: stable angina, congestive heart failure, acute MI, pericarditis, unstable angina. And this is my third case presentation, 72-year-old female with multiple risk factors with worsening chest pain. ECG shows ST depression in leads V1 to V3, no elevation in troponin, echo normal. Again, what is the diagnosis? Is it stable angina, acute non-ST elevation MI, pericarditis, or unstable angina? Again, this is the clinical context for this diagnosis. Now coming into my talk, there are few terminology that everyone need to understand in understanding coronary artery disease, where the presentation or the disease process can be acute or chronic. In chronic disease, there is the manifestation can be asymptomatic, or they can have what is called a stable angina, where the disease is progressing slower and people will have symptoms on exertion. That's the triad that people will talk about as you're going to start seeing patients: angina pectoris, chest pain on exertion, relieved by rest, and or nitroglycerin. That's the classic triad for angina. It should always come on exertion. Any chest symptom, then there should be suspicion for chronic coronary artery disease. Or it can be an acute manifestation of coronary artery disease, which is unstable angina. Again, as the name indicates, angina means lack of blood supply to the myocardium or ischemia of the heart. That's why it's called angina. Here again, it's the same thing: pain, chest pain or shortness of breath. But here the severity is much worse. People will have pain even on walking from the bed to the bathroom, or walking around the house, or if it's progressively worsening in a short period of time. All this are indication that the disease is progressing faster. And then there is this end result of all this, which is called acute myocardial infarction. So if the muscle is dead, then it's called acute MI. That constitutes the primary burden of cardiovascular disease, and many cardiologists work to treat them or prevent them. So in terms of more terminologies: acute coronary syndrome versus acute myocardial infarction. People used to diagnose heart attack as only acute myocardial infarction. It was because of the technology that was prevalent in those days, where they were just doing EKG and diagnosing acute myocardial infarction. But as the knowledge kept on growing, where we had access to looking at the coronary artery here, supplying the heart, and understanding the disease pathology, the terminology has changed over time. So acute coronary syndrome is primarily from occluded atherosclerotic disease, and it can lead to unstable angina or myocardial infarction. And myocardial infarction is thus a form of acute coronary syndrome where the blood flow is totally cut off. And distinct from these two is myocardial injury without ischemia, where the myocardium can be damaged independent of blood flow due to toxins, heavy metals, alcohol, arrhythmia. So even if somebody comes in with signs of myocardial and injury, they have Q waves, or if they have heart failure, you have to rule out acute coronary syndrome or chronic coronary artery disease first in terms of evaluating the heart disease. As you see here, myocardial ischemia is a supply-demand mismatch. So it's the balance between the flow to the muscle and the demand of the muscle. Heart being the most dynamic muscle in the body. When we exercise, when we, are mostly during exertion, the myocardial demand goes up high. So if the coronary artery is blocked, and as the blockage is going up, then symptoms will manifest accordingly. So earlier in the disease process, as you see here in the bottom, I'm using my pointer here. Earlier in the disease process, when the lumen is just 30%, 40% blocked, the symptoms may not be prevalent. And nowadays we use imaging technologies, and there are a lot of upcoming images like strain echocardiography, MRI, myocardial perfusion scan, or nuclear scan that can pick up the earlier decrease in blood flow and myocardial function. But as the disease is progressing, let's say here the blockage is about 80%, then ECG will show those changes. And again, as I pointed out in the beginning, people were looking at this disease from the EKG diagnosis. That's of myocardial infarction was coined. And as we were doing more angiogram and other imaging modalities, we have picked up the earlier disease. One great example is coronary CT. It can look at the blockage in the blood vessel even at an earlier stage. And only when the disease is progressed to the point of above 90% blockage, or even 70% blockage, people will have angina. If they have 100% blockage, they have acute coronary syndrome. So with this being the disease spectrum, the global burden of coronary artery disease is pretty significant. This is looking at the coronary artery disease burden across the globe. And the graph, the map shows the mortality rate per 100,000. Here we are talking, they are showing the male mortality rate. In the bottom is the female mortality rate. And if you look at the graphical representation, you would see that in the North America and South America, it's mostly around 15 per 100,000. Whereas main of Eurasia, it's about 30 per 100,000, the mortality rate. So it's pretty significant, especially in low and middle income countries, that deaths occur even at younger ages, which is posing a higher burden at a population level. Also, we do not have a lot of data coming from these countries. There is more research that are being done only these days. Now, moving on to the pathophysiology and risk factors for acute coronary syndrome. As I told you, it's a vessel problem. So the majority of the cause for acute coronary syndrome and myocardial infarction is atherosclerosis. And there is also non-atherosclerotic causes, which I'm not going to go over here. I'm going to mostly focus on atherosclerotic vascular disease, which is the primary cause for acute coronary syndrome. So in terms of atherosclerosis progression, as I was showing earlier, it starts with fatty deposition, with overlay of macrophages, smooth muscle cells, which then try to heal the vessel wall by forming a fibrous cap. And as the disease process gets further aggravated, which is again due to multiple risk factors worsening the progression, the plaque can become thinner with a large necrotic lipid core that leads to break in the plaque called as plaque rupture, or vulnerable plaque rupture or erosion, leading to acute presentation of the atherosclerotic disease. So that's what I've circled here. If there is unstable plaque, that could be even 60% blocking the artery. But if due to shear stress or elevated blood pressure or increased demand, that plaque can break. And these are that's very hard to show in a patient coming in with myocardial infarction, what exactly made the plaque to rupture. But those are some of the factors that have been popping up in research studies. So plaque rupture leading to acute coronary syndrome is a very hot topic in cardiovascular research because it will save millions of lives. Whereas in stable angina, it's more of a slowly progressive disease. And talking about risk factors, it's mostly diet. In the US, it's mostly these burgers. In fact, there is a grill that's called heart attack grill. It's a combination of high fat diet, fried food, sugar and carb rich diet. That's not good for the blood vessels. It's going to tip off that plaque from stable to unstable plaque. Similarly in India, again, the sweets, the fried food, those are all a reason for aggravating inflammation and fatty deposition in the blood vessels. More than that, now with development and urbanization, there is more sedentary behavior, and that also accelerate atherosclerosis. So when you look at the risk factors, you can classify them as non-modifiable risk factor and modifiable risk factors. And non-modifiable risk factors, you have age, sex, male being more predominantly at risk for having acute coronary syndrome, ethnicity, Indian, South Asians, non-Hispanic Blacks tend to have accelerated atherosclerosis, or their presentation is typically acute coronary syndrome or early death, premature coronary artery disease. It's not clear if the diet is playing a role or if there are other genetic factors that is playing a role. And this is much more worse if they immigrate to a developed nation like the US or UK, where there is more change in the diet and the environmental factors. Familial hyperlipidemia, because it's the cholesterol that is going to cause the initial, fatty streak in the blood vessel. And if people are having genetic defects, they can easily bombard the vessel with multiple fatty deposits. And positive family history, that's a non-modifiable factor too. If someone in male family member before age 55 and female family member before age 65. Now coming to modifiable risk factors, I talked about diet and sedentary behavior, but those actually contribute to pre-existing risk factors like diabetes, hypertension, dyslipidemia, obesity, plus smoking. Smoking per se, if someone is smoking without and still exercising and following a good diet, they have a higher risk of developing acute coronary syndrome or coronary artery disease. Those are all traditional risk factors which has been studied from early 1900s. Now moving on to non-traditional risk factors or novel risk factors, because you do see coronary artery disease and acute coronary syndrome in people without known risk factors. And that's how these factors have been looked at. Some are inherent, lipoprotein A, which is involved in lipid metabolism, fibrinogen, homocystinemia, and there are novel environmental factors like air pollution, noise pollution, viral infections, including HIV, influenza, even COVID-19 or SARS-1 has been shown to cause worsening atherosclerosis. And that is going to take, especially for COVID, we will know more over the, in the future, maybe when you guys graduate out of medical school and do in practice, we will learn more about the after effects of this pandemic. Psychosocial factors, depression, extreme anxiety, type 1 personality, or type A personality, they have been looked into developing early onset of acute coronary syndrome. Also socioeconomic inequalities. Thus, coronary artery disease is multifactorial, and the main thing that has been emphasized in terms of modifying the risk is diet and heart healthy diet and physical activity. Again, going back to the coronary arteries and the atherosclerosis, we have a stable plaque, which has fatty deposition and fibrous cap overlaying it, which leads to narrowing of the blood vessel. And because it's a slowly progressing disease, people experience symptoms on exertion. For this process, hypertension and increasing age is considered to be most important risk factor. Whereas in the unstable plaque, where the plaque gets weak, it can easily rupture and lead to thrombus that is rich in platelet, or clot, fibrin-rich clot. These two are important to know because it is going to change the management of patients when they come in with acute coronary syndrome. So for this kind of plaque, smoking, hyperlipidemia are considered to be worsening factors. So if someone is smoking, they were shown to have more vulnerable plaques. So it's important to know which risk factor will play a role in the acute manifestation. So any questions so far? We are good? All right. Now moving on to the diagnosis. Again, this is an overview showing that stable angina comes from fixed atherosclerotic plaque, and unstable plaque is been shown to be the culprit lesion for unstable angina and non-ST elevation MI, ST elevation MI, which I'll go over in detail in the coming slides. So these three constitute acute coronary syndromes because the plaque morphology is again same. So when the stenosis is above 60%, people experience symptoms on exertion, leading to stable angina. In acute coronary syndromes, symptoms occur mostly during resting. And when you look at the myocardium, if there is less so the blood supply goes from inside out. When there is blockage in a blood vessel, the blood supply to the innermost myocardium, called the subendocardium, is cut off. And this entire in this early stage of ischemia, only that inner layer is prone to get damaged. So that's called as pre-infarct angina or unstable angina. I'm going to use unstable angina, which is the most commonly used terminology now. And if the infarction is progressing from that subendocardium to about half the way, then it's called as non-ST elevation MI or non-ST elevation acute coronary syndrome. And if the infarct or if the entire muscle thickness is gone due to lack of blood supply, it's called ST elevation MI, which is a transmural myocardial infarction, which you'll be reading in pathology soon. So what we also diagnose stable angina based on clinical presentation and some imaging criteria. When people have chest pain on exertion with underlying risk factors, and if we have one objective or imaging criteria, then they are characterized to have stable angina. So in cardiology, we have access to a lot of imaging modalities. We can make people walk on treadmill, monitor their EKG changes, or look at the heart function by nuclear scan or echo, and look at the change in the myocardial perfusion or blood supply and function, which is contraction of the wall during exercise and rest. So when the blood flow is compromised, we'll see some changes in the myocardium. In unstable angina, again, there are many statements that have come out for unstable angina and acute coronary syndrome. The important criteria is that patients need to have rest angina or worsening of angina by severity. They will also have EKG evidence of ischemia during rest. And we have what is called as cardiac biomarkers, which come from the dead myocardium. It's troponin, and that won't be elevated in angina. Whereas in myocardial infarction, it will be elevated. So this is fairly recent from 2018. There has been progressive definition of MI based on the tools and technology that we use. It's important thing that distinguishes between unstable angina and infarction is troponin, which is the myocardial skeleton protein. So it is acute myocardial infarction is when the troponin rises and falls because of the dead tissue. And one of the following criteria need to be met to come up with the diagnosis of myocardial infarction. It can be symptoms or EKG changes or imaging evidence or angiographic finding, which is looking at the coronary artery directly. And based on the pathophysiology, now myocardial infarction can be further classified. I'm not going to go into details. But again, coming to the diagnosis of acute coronary syndrome, when the vessel is more than 90% stenosed or 100% occluded, there is infarction in the myocardium. For unstable angina, troponin is negative. There are STT changes, which represent blood supply to the myocardium. And there will be loss of contraction of the myocardium by echo. We call it as regional wall motion abnormality. And in angiogram, you can find 90 to 100% blockage. In non-ST elevation MI, there is elevation of troponin. There will be EKG changes. There will be positive, there will be decreased contraction of the heart by imaging modalities. And again, angiogram might show 90 to 100%. In ST elevation MI, which is the most life-threatening presentation, sometimes even precedes sudden death when patients can't even come to the hospital. There is higher increase in troponin. There is ST elevation. The heart muscle won't be moving well, and there is 100% blockage. So in terms of the approach to diagnosis, if someone is coming in with ischemic symptoms for myocardial ischemia infection, You have to assess if they have it on exertion or if they are present at rest and escalating in severity. And if it is on exertion, then basically rule out stable angina when you put them on an exercise treadmill test and come to a conclusive diagnosis. Now, people also use coronary CT to look at the blockage of the blood vessels. Whereas if there is someone who has symptoms at rest, you check their troponin. If the troponin is negative and they have EKG changes, it is more likely unstable angina. If they have troponin positive, it's more likely myocardial infarction. And there is always going to be some overlap and tricky situation, which we'll come across in practice, especially as a cardiologist. For now, those things are important to remember and learn. So coming back to the cases, my first patient, 83-year-old male with hypertension, diabetes, tobacco abuse. He developed chest pain with weakness. His EKG showed ST depression in V1 to V3, normal sinus rhythm. His troponin was elevated. So all that is pointing towards acute non-ST elevation MI. Again, I will be talking to you about the difference between ST depression and ST elevation soon, but it is an acute myocardial infarction, basically. The second patient who presented with chest pain on exertion and a positive echocardiogram showing wall motion abnormality and no EKG changes. The diagnosis is stable angina because his troponin was negative. In our other patient who had multiple risk factors for coronary artery disease and who had progressively worsening chest pain, EKG showed ST depression, but no elevation in troponin. Echocardiogram showed mildly decreased right ventricular function. And that's from unstable angina. So these three cases represent the diagnostic steps that I discussed earlier. So you guys can go over it again or look up and register it later. Again, overview of the approach to the diagnosis of acute coronary syndrome, where apart from clinical presentation, it's good to have a blood test for troponin, get EKG. By doing just a good history, physical, doing EKG and doing blood work, one can narrow the diagnosis to unstable angina and myocardial infarction. And the remaining thing, echocardiogram, angiogram, autopsy, if somebody has died, will only confirm the diagnosis. So moving on to the actual imaging EKG criteria, one has to first understand the coronary circulation and the corresponding myocardial distribution. So in the heart, there are two main blood vessels that come off from the aorta, the right coronary artery and the left main coronary artery. From the left main comes the left circumflex and left anterior descending. Left anterior descending supplies majority of the left ventricle and the heart. It supplies the anterior wall, IV septum, sometimes inferior wall. Left circumflex coronary artery supplies lateral and posterior wall and the papillary muscle. And right coronary artery supplies the right ventricle and inferior wall. So it's important to understand the anatomy and the myocardial distribution in terms of localization of the myocardial infarction when you look at somebody's EKG and the way they present. But it's also important to know the anatomy, because depending on where the blood supply is cut off, there would be complications that occur due to myocardial infarction. Now, the most common technology and the old that is being used in the diagnosis of myocardial infarction and acute coronary syndrome is 12-lead EKG. These are the leads, and this is a cartoon that shows which lead represent which blood vessel distribution. You'll be spending a lot of time learning EKG, and there is a lot to learn from EKGs, but this one is more focused on just acute coronary syndrome and myocardial infarction. So there are limb leads, the lead 1, 2, 3, AVR, AVL, AVF, and the precordial leads, which is from V1 to V6, that goes across the chest. So if the right coronary artery is affected, then there'll be changes in lead 2, 3, and AVF. If the left anterior descending artery is affected, then it'll involve V1 to V4. And if the lateral wall is affected, it's reflected in V5 to V6. Again, we can spend a whole 1 hour looking at EKGs. This is just an overview for you all to basically get the concept that we can localize which wall is affected based on a 12-lead EKG. Now, looking at the EKG ECG waves, P, Q, RS, and ST segment. So each wave represents each segment of the heart. ST is more specific for the myocardial ischemia. And how to evaluate ST elevation is look at the PRs or PQ segment and see how much the ST has gone up. That's the ST segment elevation. Similarly, compared to the baseline, how much it comes down as ST depression. So here, looking at the ST segments, you can see in the second tracing, it's called ST elevation MI because it's way up here, and that's because the myocardium is not getting enough blood supply. And if you see this finding in the limb leads and the precordial leads, you can diagnose where exactly the MI is occurring. Same with the non-ST elevation, where the segment goes down instead of going up. That's how the non-ST elevation came into play. And T-wave inversion is also a manifestation of ischemia. Now, I'm not going to go over this in detail. This is just for completion. I put the exact criteria. So we are looking at these small boxes in the 12-lead EKG, and the cutoff we need to remember for ST elevation is 1 millimeter. So from the baseline, if the segment is gone up by 1 millimeter or one small box in the precordial leads, then at least in 2 contiguous leads, then you have to think about ST elevation MI in someone with chest pain. Or a new left bundle branch block is considered to be ST elevation MI too. For ST depression, it's more than or equal to 0.5 millimeter or half a small box in 2 contiguous leads. This is an example of a 12-lead EKG in a 58-year-old male with smoking who presented with sudden chest pain. And here, again, the R to R interval is regular. There is no widening of the QRS complexes, but you do see some abnormality in the ST segment here. So what's going on here is a very significant ST elevation or hyperacute T waves. That's what we call this as. And you can see that the segment has gone up more than 1 millimeter, right? This is almost one big box, 5 millimeter ST elevation. And we see that in V1, V2, V1 to V4, And you also see some ST depression in lead 2, 3, AVF. So what we refer to them are reciprocal changes. So if there are, it's again based on the orientation of the leads. When the leads are picking up the ST elevation from the anterior part, and the posterior part of the leads looking at the ventricle from the other side are showing mirror images. That's what it reflects. So because we see ST elevation in lead 1, AVL V1 to V4, it is consistent with anterior STEMI. It is most likely from proximal left anterior descending artery, or it could be even left main. But here V5, V6 represents lateral wall. So there the ST segments are not shifted. So this is more conclusive for anterior ST elevation MI. So if you see someone with this EKG, sudden chest pain, even one significant risk factor, putting everything together, you have to now think in your mind, this is someone who has that vulnerable plaque, acute presentation, now ST is elevated. With such a significant presentation, it's unlikely to be unstable angina. Get the troponin, you'll see that it'll be like way above and meeting the criteria for ST elevation MI. They need to get to the hospital right away and into the cardiologist, interventional cardiologist hand or fibrinolysis. I'll talk about it soon. This is another EKG from a 75-year-old female who was getting pre-op workup. And what do you see here? We see, instead of tall R waves, we are seeing deep Q waves. So again, here the ST is flat, similar to PR interval. So there is no evidence of acute ischemia. But when you see these deep Q waves, it is suggestive of old myocardial infarction. Again, we can localize based on the limb leads and the precordial leads involved. Here it's V1 to V3, suggestive of anterior wall. Another EKG from a 67-year-old with chest pain and dyspnea. Again, we are seeing ST elevation and leads 2, 3, AVF, which look at the inferior wall of the myocardium. So this shows evidence of inferior wall MI. Again, in AVL and lead 1, you see ST depression, which are reciprocal changes again. Another EKG where a 45-year-old male with hyperlipidemia and epigastric discomfort and nausea. Actually, let me. Oops. Okay. So here you can tell that the ST segments are elevated in these 2, 3 AVF. But you, compared to the previous EKG, you will also see that the anterior STs are down, as well as the lateral walls are going up. So this is more of a diffuse ST changes. When you see such diffuse changes, you need to be thinking about huge myocardial infarction. So here are the changes. But here, because of the inferior wall involvement, V5, V6, again showing ST elevation, we have to think about posterior wall involvement. It's just that left circumflex that covers the lateral wall and goes posteriorly. So in this case, we sometimes move the precordial leads into axillary and posterior region of the wall to capture that posterior wall of the myocardium. This summarizes the features of posterior wall MI. I'll skip that for now. 55-year-old female with worsening chest pain. Again, we are seeing more of inferior and lateral wall involvement. Here, there is no ST elevation, but you see ST depression. So ST depression and 2-3 AVF. And there is also some ST, you always look for ST elevation in any of the leads. You have to pay attention to AVR because it can show, it can represent left main disease, which is again a bigger involvement of the myocardium. Here, however, it's not more than 1 millimeter and hence not concerning. I just wanted to point that out here. So this one is suggestive of infralateral non-ST elevation myocardial infarction or acute coronary syndrome. So EKG is the cornerstone. It's used by many internal medicine physicians, emergency room doctors. But when a patient comes to a cardiologist, we use echocardiogram. Nowadays, in some centers, coronary CT, MRI, nuclear stress test. Those all will detect lack of proper contraction of the myocardium. These are images that we get from the echocardiogram looking at the heart in different orientation. This is called as the donut view, cross-section of the ventricle. If they are not squeezing well, and depending on the lack of blood supply to the particular area, that part won't move, whereas others will move. Color here indicates flow inside the heart across the valves. So if there is any valve regurgitation, we can see that as mixing of blood. Again, I'm not going to go into details, just showing that there are many modalities that we use in the diagnosis of acute coronary syndrome. This is an image from coronary CTA looking at left coronary circulation, right coronary, and this is sagittal section showing a proximal LAD left main disease. Not fully occluded, it's like 40%. So he needs to be under intense lifestyle modification and risk factor control. Now, when someone is presenting to the emergency room in the hospital with signs and symptoms concerning for acute coronary syndrome, they are taken to the cath lab. They get a dye into the radial artery or femoral artery, and we can look at the coronary arteries by angiogram, which is not only diagnostic, but also used for treatment. I'll go over it in the next few slides. So angiogram in a patient presenting with inferior wall where the right coronary artery is blocked, you see that the distal part is not filling well. Same here. On the left side, another patient where the proximal left anterior descending artery is occluded. Not fully, if it is fully occluded, you won't see anything distal to it. This is angiogram of the left coronary artery narrowing in a different patient. Now, why do we have to be worried about acute coronary syndrome, and what happens if they are not taken to the hospital on time, or if they ignore symptoms at home and there is a huge damage to the muscle or the myocardium? Depending on the extent of involvement, the complications of myocardial infarction could be lack of contraction of the myocardium leading to thrombus or decreased blood pressure, cardiogenic shock, congestive heart failure. Sometimes it can lead to valve dysfunction, and mitral regurgitation as one of the manifestation of acute coronary syndrome. Or they can even rupture that infarcted myocardium leading to tamponade, where there is blood around the heart. All these will present as hypotension, collapse in an individual, shortness of breath, or, syncope. So all these are something one need to be aware of as the complication of myocardial infarction. There are other complications too, which are arrhythmias and pericarditis. So time sequence of these complications, the immediate complication that one need to be aware of in the first 48 hours of presentation: ventricular arrhythmias, death, cardiogenic shock, acute congestive heart failure. So it's highly important that the vessel need to be opened right away. If it is beyond 2 days, then depending on the wall involved, it can lead to a ventricular septal defect, mitral regurgitation, cardiac tamponade, and pericarditis. Sometimes, if the vessel is not opened and the myocardium is dead, then it can lead to aneurysm and pericarditis. Again, an example of pericarditis, which again affects the ST elevation, but here it's concave upwards and it's diffuse. So it's important to think about this in someone presenting with chest pain, with inspiration that's worse, like pleurisy. Again, this should be in one of the differential for ST elevation MR. Coming to management, the management need to be focused on treating symptoms, but also to prevent complications in a timely manner. And here, the management of STEMI is somewhat different because of the plaque differences I mentioned in the beginning from non-STEMI. Again, once you do the EKG, you'll know which pathway one needs to get into. And we also have risk assessment tools. Again, this is probably too much for you guys. A goal of treatment is to decrease the myocardial oxygen demand and improve the blood flow. So to decrease the demand, we give them nitrates, beta blockers, renin-angiotensin inhibitors. To improve blood flow, we take them to the cath lab, open up the blood vessel. Sometimes they need bypass surgery. And if those facilities are not there, we can still give them fibrinolytics. And it's not just enough to open up the blood vessel. We also have to make sure that this clot formation doesn't occur in other blood vessels. So they need to be given antiplatelet agents and systemic anticoagulants. And anybody with MI should not get NSAIDs or steroids. People used to give these treatments for patients with acute MI, but instead of treating, they actually led to more complications, especially the muscle was not healing well and it would rupture, lead to ventricular septal defect and cardiac tamponade that I talked about earlier. So reperfusion strategies in acute coronary syndrome. This is cornerstone of treatment in terms of improving mortality, improving survival, and decreasing mortality. So time is muscle in management of acute coronary syndrome. So if somebody is coming into the emergency room, just look at this diagram. They need to get the EKG in less than 10 minutes. Within 30 minutes, they have to get fibrinolytics. That's in a non-PCI center. But if they have access to PCI, then they go to the cath lab and preferably get the artery opened in less than 90 minutes. So that's why we call it as time as muscle. The earlier we open the blood vessels, or an interventional cardiologist open the blood vessels, the better the prognosis and decreased risk of complications. Now, as I showed earlier, in unstable plaque, there is this platelet-rich thrombus plus a fibrin-rich clot, which is the reason for 100% occlusion and ST elevation MI. And that is the reason why we use fibrinolytic agents in ST elevation MI, but not in non-ST elevation MI. Again, this is an important pathophysiologic concept that you guys have to keep in mind from now on until any time you're going to practice. So fibrinolysis and fibrinolytic agents play an important role in opening up that blocked artery. In olden days, people were just given this. They would be looking at the EKG for resolution of ST elevation. And we look at similar parameters even now, but the advantage of having cath lab is that patients can still be taken to the cath lab once they are stable, and they can get rescue PCI. These are some examples of PCI, which is percutaneous intervention in patients coming with acute coronary syndrome. Example, this one I showed you earlier is a blocked right coronary artery, but when they get angiogram and balloon angioplasty with stent, the blockage and the flow blockage is opened up and the blood flow is restored. That's why they are called, I mean, most often interventional cardiologists are referred to as plumbers of the heart, because they literally go and open up the blockage and put a stent to keep the blood vessel open. This is a left coronary system that's totally occluded, and they've put a nice stent here to restore the blood flow distally. So this entire myocardium is salvaged. Again, timing is very important to do this. There'll be circumstances where the blood vessel could be opened up, but if the myocardium is almost dead, it's dead and gone. It's going to be hard to recover. Now, what are some of the treatments that we use in acute coronary syndrome? Mainly to prevent progression of that blockage in the blood vessel, in the culprit lesion, as well as in other arteries. They are antiplatelet agents and anticoagulant agents. So antiplatelet, aspirin, we load them with 325 milligram aspirin, regardless of ST, non-ST, or unstable angina. And we also use newer antiplatelet agents, which are called P2Y12 antagonist, clopidogrel, prasugrel, ticagrelor. There are also IV intravenous agents, which we use with PCI. Again, they have to be used only within during the procedure time. Otherwise, it can lead to bleeding complications. So it was overused in the beginning. Now people are using it more cautiously. Regardless, we give them anticoagulants. These are used even with fibrinolytic agents and PCI. And these are unfractionated heparin and enoxaparin. That's the management of acute coronary syndrome, but our treatment doesn't stop there. We also look at the patient long-term in terms of preventing another event and to make sure they are not developing complications. So it's a lifelong follow-up. So typically when someone comes in with acute coronary syndrome, they get statin, antiplatelet agents, which is aspirin, and the P2Y12 antagonist I mentioned about, beta blockers, RAS inhibitors. Those are to decrease myocardial demand. Sometimes we give them extra medications to treat symptoms. And again, we shouldn't forget about risk factor control and lifestyle modification, smoking cessation, and rehab, heart healthy diet. So to conclude, in terms of diagnosis, understanding the pathophysiology of atherosclerosis progression is important. and that helps in understanding the clinical EKG and imaging criteria. I also have to identify the different types of MI for timely reperfusion, use of fibrinolysis, and avoiding complications. So in terms of management, time is muscle, 30 minutes for fibrinolytics, total ischemic time is 120 minutes. Use anticoagulants and antiplatelets to prevent reocclusion, and medical management to improve oxygenation and secondary prevention. So I would like to acknowledge our KMC organizers for giving me the opportunity, and also all the places which trained me.
Hey, I think this is one of the stellar presentations. Actually, I learned quite a bit, and it's a perfect refresher course. And to the students that are attending, it may probably be a little bit over your head and too much for you now, but just save these slides. You will definitely thank your lucky stars that you were here for this presentation, because she had classified the acute coronary syndrome and the MI and the differentiation so well that you may not get those in textbooks. I'm telling you, you will not find that in textbooks. Even today, if you have to locate that, you should have to go look to see exactly what the coin terms mean. But she had probably done her research and had put it in such a concise manner. Save these slides. I mean, I'm sincerely letting you know, it was such a great refresher course. And thank you, Ranjini, for doing such an excellent job.
Oh, thanks,
I really loved it. And I actually would like to get those slides. Actually, I would like for you to share the slides with me. And I do not know how the recording is available. How do they access recording? Does anyone know, or anyone can throw light on that?
We are uploading the videos recordings in YouTube. We'll be sharing the link. After completing the classes as a bunch, we will be uploading and we'll be sending.
Acha, got you. So anyway, so how long are you thinking that it is going to take? Because, our sessions, this is going to be, there is only one more session for this kind, Saturday session. We are stopping it, as you all may know, that we are holding it off until further notice from January. We're not going to have these sessions. So I just was wondering what are going to be the status of the existing sessions that have been uploaded, or how you will be uploading it and just putting it, and you will be giving us the notification, Dr. Nandakumar?
Most of the class sessions have been uploaded already, ma'am.
Already. Okay, got you.
Within a week or two, we will be sending the link, ma'am.
Okay. So where do we go find the link? I mean, do you send a separate link out, or is it like we got to go find the link?
No, ma'am. We are having the link. We are uploaded it into a YouTube channel, ma'am.
So what's the name of the channel that we need to go into?
But we didn't share it to others,
it will be good to have.
Because if we share it to others, means they won't be attending the class now, ma'am. Because they know that they'll be recording. So we are waiting to release.
Understand. I totally understand. For us to review, for people to review, how do they access back? So they just go to YouTube, and what do they type in to go access this recording?
I will share you the link separately, ma'am.
Okay.
Privately, but we can't share it publicly, ma'am.
Oh, yeah. No worries at all. So I will ask, and then I will have you share the link with me. I mean, I just wanted to have it and then I would like to have the slides, Ranjini, whenever you have the time.
Yeah. I will clean up a bit more and send it to share it with you.
But it was a great presentation, and thank you all.
Thanks, Maithili. I'm glad some of you could join, and good to know there'll be recorded video for others.
It was a great presentation. Thank you.
And
thank you all.
Please
thank
come
you,
up with, if they have any questions, you can.
Yes.
I'll send you my email ID. And
you can share. I mean, they have your number. They can always WhatsApp you too.
Yeah, right? WhatsApp me actually. That's I check WhatsApp daily, so you can WhatsApp me. If it goes beyond WhatsApp, I can email you. Yeah.
Ma'am, question. I'm very sorry to interrupt, ma'am. Can I ask a question if it's okay?
Of course, I want it to be more interactive, and whatever question you want to ask, please do in the
Yes, ma'am. So thank you so much for shedding a little, I should say a lot of light. Only some of it we've been able to understand. Hopefully, that is most of it we have understood, but I think the processing will take us some time, like Maithili ma'am.
Yeah, exactly. And you're only in your second year, and
yes, ma'am.
I wasn't sure who all will be attending. I had to focus it for a broader audience. I can totally understand.
Unfortunately, in India, they don't have the clinical starting at second year. They start
second year. Yeah, Maithili. I realized as I was going through, oh no, how I wonder how they would understand.
Go ahead with your question now. So,
yeah.
Yes, ma'am. Ma'am, actually, we do have postings and we do see some MI patients, but we don't have cardiology in our internal medicine rotation. So what happens is we don't see a lot of we see EKGs, but we don't see the patient or do the history. So we see only the sometimes very rarely we see only the ECGs, ma'am, and we see the diagnosis. So it's actually with regards to that only, ma'am. So most of the ECGs, I could understand the changes you pointed out, ma'am, like through the markers and all. But when we look at the ECG as such, that is without any of those annotations, it seems very, I don't know, ma'am. It's very confusing. Is there any way to like simplify the ECG?
So you need a basic EKG class. That is what it is. What each lead stands for. Yes.
Yeah.
Okay. We will try to arrange that. We will try to arrange that at some point in time. We will definitely have, and Dr. Ranjini probably can be the one that can mentor you. And we will arrange.
Yeah, I can help you with that. I can now that you.
There are other people to each. We can assign different students to different cardiologists. There's only a wealth of alumni who are cardiologists. So I'm sure there are many people who can help you out. We can definitely look into that as far as an EKG class. I can't bring KB Mishra here. He's I don't know where he is. But I can definitely bring anybody very short of KB Mishra. And we'll see how we can get that arranged.
But for now, since you guys have access to internet and Google, you can just go to YouTube and search for approach to EKG. There are a lot of videos floating around in YouTube and Google. Even in Google, you can say approach to 12-lead EKG, and there are many links there. That I can also look up and see what would be relevant for your level, and I can put it in our group. And I get
actually, what I understand where the student is coming from, I think it is much better if somebody sits and explains to them and makes it as a class. I think that's what they want.
That's by the time we arrange, Maithili, I think if they see, for it has to be also everyday thinking process until it gets registered.
Yeah. So we will try to. I will talk to Dr. Prasad, and I will talk to one of the share and learn colleagues there. They're doing some daily lessons, so they maybe one of them can sit down for an
in India, Maithili? In India, you mean?
India, there's a share and learn session that is going on every day, and I'm sure many students, so they as a part of one of those sessions, they can also do EKGs,
And I would suggest you can also, if you can make copies, Xerox or photocopy, and keep some of the EKGs and go over with the specialists there in person. That would be very helpful. But let me know, Maithili. I can plan for EKG. I will start looking into organizing.
Did that answer your question, sir?
Yes, ma'am. Thank you so much, ma'am. Both to Maithili ma'am and to Ranjini ma'am, because there's been something going on in my mind, and since I think we've had more than a couple of I think of these Saturday sessions which hit I don't know, some hinted on ECG, some focused more. So I was just going through, and I think these tips generally I think will really help us, ma'am. Thank you so much for it.
Definitely, we can arrange for a dedicated EKG class.
Yeah, exactly.
All right. So any other concerns? yeah, if that's the case, then I think we can say adios. Thank you so much. Thank you, everybody.
Oh, thanks, Maithili, for being the anchor. It's a different experience, and I hope it'll inspire you to learn more about cardiology too. And
whether it inspires other people or not, it has inspired me. I've learned a lot, so I'm okay.
Oh, you're welcome, Maithili.
All right. Okay.
All right. Thank you.
All.
Thanks for arranging all this. Thanks. Thanks.
Thank you.
Bye.
Thank you all. Bye-bye.
Thank you,
Nanda.
You're
Thank
welcome.
you all.
Thank you.
Bye.
Bye.